Actually, it's not a new technique, EMR. It's an old technique, but just a global overview over endoscopic mucosal resection. Actually, the first case of endoscopic polypectomy done in 1973. Before this era, surgery was the only solution for any GI polyp. This is famous slides, which lesion we have to remove by endoscopic mucosal resection. You see M1, M2, M3 mucosa according to the level of depth of the lesion. Mostly of the colonic wall ranging from 2.7 to 3.5 millimeters. As we see, endoscopic mucosal resection is restricted only to M1 and M2, and sometimes in expanded criteria to M3. Before the era of video scopes and almost high definition chroma endoscopy and MPI, EMR and ESD, just a new techniques developed in the after 2000 something. Before that, surgery, you see, is the only solution for any GI polyps. First of all, you have all of us know about the Kudo classification of the big pattern mucosa. We move only polyp starting from type 3 to type 5. Also, Paris classifications. We have to know all about the three classifications of Paris. It's not working. We only, EMR is restricted to stage 2B. Sometimes in expanded criteria to C. All of us have to, when he underwent resection, you have to work with high definition scope. Actually, not all of us, especially in the الحكومة ما بقاش فيها المناظير دي، بس actually يعني شايفين المنظر في ال conventional scope والhigh definition scope. The idea of EMR and or even ESD is to detect the lesion from the start. أنا ممكن لو أنا بشتغل في الناحية اليمين بالconventional ممكن الحتة دي تمزد مني. ففي فرق جامد طبعا ما بين الاثنين. According برضه في الأوضة اللي جنبنا شغالة الأوبتيكال دايجنوزس، الكروما اندوسكوبي والام بي اي. الليجن في الكونفنشنال سكوب في الصوره رقم A والمنظر في الرقم C ده بيختلف تماما يعني. فالفكره برضو ان بره الواحد لما يجي يشتغل بيجي يشيلها في نفس الوقت. لو هو شايف ان هو في ليجن high probability of dysplasia or even neoplasia بيشيلها في نفس الوقت. احنا هنا الهابتس ان احنا ناخد بايوبسيس اكشولي ثبت ان هي مش مطلوبه اصلا، هي بتنديوس سب ميكوزال فايبروزس. دي عندنا منظر في الكورون فلات ادينوما، طبعا دي ممكن تمس بالكونفنشنال سكوب، لكن المنظر زي ده اكشولي وي كان امبوسيبل ان احنا نحددها بالكونفنشنال سكوب. GI lesion resectable or not according to many criteria, according to size, 1 centimeters, 2 centimeters or more, shape, non-polypoidal lesions. The breast lesion is more difficult to remove. The appearance, thickened fold or converging fold or ulceration is high probability of malignant transformation. Also, surface analysis and Kudo classifications. Lifting signs actually is one of the crucial sign of endoscopic mucosal resection. When the lesion didn't lift, don't remove. Endoscopic resection in general is indicated if the lesion is identified for sure, actual characterization and delineation of the lesion, low risk of lymph nodes metastasis, complete resection and block resection is better than piecemeal. Material available for detailed pathological analysis, low risk of metachronous lesion, safety and available expertise for sure, structure in the endoscopy unit for follow-up. Outcome parameters of EMR, we have in-block resection in a single piece without the fragmentation. The more the in-block resection, the less the recurrence of the lesion. R0 resection, this means that lateral and vertical margin are free of neoplasia. Curative resection means that when we achieve our zero resection and after histopathological analysis, no lymphatic and or venous infiltration, no undifferentiated areas. According to guideline criteria of Japanese Society of Gastrointestinal Endoscopy, mucosal EMR is limited to mucosal adenocarcinoma or dysplasia before high grade or low grade, M1, M2, sorry, zero lymph node metastasis, differentiated tumor, elevated less than 2 centimeters, no ulceration, invasion limited to the mucosa on the basis of AOS. Sometimes we, especially in the right side column, crucial rule of non-elevation, elevation or non-elevation by lifting signs, expanded criteria, M3 SM1 ulcerated lesion below 3 centimeters. You see here is only the one with the light blue, the only indication for EMR, lesion, non-ulcerated lesion below 2 centimeters. General consideration regarding EMR or ESD, intramucosal, the maximum for the criteria, intramucosal adenocarcinoma, measuring less than 2 centimeters, the microscopic doesn't matter, either flat or elevated. There is no finding of ulceration. The expanded indication that non-ulcerated lesion differentiated carcinoma more than 2 centimeters. This is also only in the Japanese guidelines. Non-ulcerated lesion differentiated carcinoma less than 3 centimeters. Non-ulcerated lesion undifferentiated less than 2 centimeters in diameter. In order to determine whether ESD or EMR is indicated, it is necessary to determine the histopathological type, the size, the depth of invasion, whether ulceration is present or not. The risk of incomplete resection is high when the EMR, the lesion with expanded indication. So ESD دكتور مدكور دكتور شيماء دكتور كريم بيخشوا على طول. لو احنا عملنا الاشتيف اللي هي الاكسباندد كرايتيريا ده معاها نيجاتيف سيرجيكال مارجن ده considered curative resection for expanded indication. Risk factor of endoscopic treatment, failure of the lesion to lift, early colon cancer with lymph node metastasis after histopathological analysis طبعا, cancer invasion of the muscularis propria, severe coagulation dysfunction. Age is not a risk factor. Anticoagulation for sure have to be stopped before the procedure according to its type. يعني. EMR preparation, we have in our endoscopy unit to have electrosurgical unit, we have flushing pump to wash the lesion or to identify the complication. Also carbon dioxide, especially in case of perforation, because make the management it better. We have equipment for EMR, saline, epinephrine, dye, needles, snares, ABC, argon plasma coagulation, clips, tattoo. If you wanted to refer the patient to another tertiary center, also retrieval basket or Rosnet. This as we said before, in-block removal of colonic polyp. Actually, it has the characteristic, if you see here from this one, it pattern classification, mostly this is tubular adenoma with low dysplasia, this type 3 or type 4, type 3 bit pattern mucosa, and this is example for piecemeal resection. The piecemeal resection disadvantage is the high rate of recurrence of the lesion after removal, and also make the pathologist job more difficult. It's simply sorry. Simply EMR تكنيك ليه كذا طريقة. بنشتغل عن طريق إن إحنا نحقن تحت في السب ميكوزا large amount ممكن توصل لحد 30 ل 50 سم. في الباند assisted EMR وفي الكاب assisted EMR different technique بس the same idea يعني. والديفكت بتاع الميكوزا الديفكت as much as we can I'll try ان انا اقفله بكليبس. For sure EMR has a complication. This case of perforation, but actually don't be panic, identify your complication and be prepared and able to treat them either by clipping or argoplasmic coagulation. Sorry. EMR steps. First steps is injection. Whatever the solution used to inject, the mainstay of EMR is to elevate the lesion. Actually, in colonic lesion, we start to work from the cecal sides and then from the anal side, except from anal lesion. Sometimes we start from the before the dentate line, and sometimes we use a lignocaine injection to decrease pain post-operative. As we see, sometimes we inject more than 50 to 60 cc of indigocarmine, or here this is the anal lesion. We start below the dentate line using lignocaine and methylene blue to decrease pain. After injection, this will be the step of resection. When you use resection, please remember this, use stiff snare in order to be able to, which is, I move this, if you see this movement, after clamping the snare, I reopen it in order to overcome any entrapped submucosa. According to the size of the lesion, I choose my snare diameter, maximum 33 millimeter. For me, I'm using a blind current at the start, and my mentor, Professor Brahim Mustafa, told me that after blind current, I'm using only coag in order to prevent bleeding. But actually, it sometimes happens, bleeding even after. This is piecemeal resection. We remove a big part, and then after that, the smaller part. Complication happened. This case of arterial bleeding, you have to identify this is the value of the water pump. And according, you can even use argoplasma coagulation or sometimes hemoclips. This is arterial spurter and managed by hemoclip application. This is another one. Perforation almost one of the horrible complications of EMR and EHCD. ده اللي خلى أحمد مذكور شعره أبيض تقريبا. احنا اصلا بعد ما بنعمل EMR بنقفل as much as we can الديفكت كله، بس لو في big perforation او big hole احنا we have to pay attention ان احنا ما بين المسافه ما بين الكليبس الثاني يكون اقل. بستارت from two edge واقفل بعد كده from the middle. دي حالة ظهر فيها الفات بلين بعد الريموفر، فبقفل from both edges then start to move to the middle. follow-up of EMR. Traditionally, after 6 and 12 months, we have to repeat endoscopy, and you see the site, and if any nodules like this case, we have to make biopsy. And if any residual lesion or deep signs of deep invasion, refer him also to ESD. With the era of endoscopic ultrasound, we found that the water submersion inside the during rectal EMR, rectal endoscopic ultrasound, there is separation between the mucosa and submucosa and the muscularis propria, and ده اللي خلى فكره الاندر ووتر اي ام ار تطلع، ان احنا بنستفيد ان احنا مش بنحقن سبميكوزا، ان الكولون ساعتها بيريتين بيريتين النورمال او النيتيف سيكنس بتاعته ممكن توصل up to 5 ملم، والسو الباورفul effect of magnifications of the water make delineation and the characterization of the lesion is more better. Yes, yes. The next slide, actually, this is a case of EMR against even all the criteria. It's a mass, rectal mass, 5 by 5 centimeters. I did this case of 5 years ago. The male patient, 92 years old, is still alive till now. He's complaining of massive bleeding per rectum, and one of my colleagues make biopsies, and biopsies adenocarcinoma. Actually, the patient refused by surgery, by the anesthesia, and the surgeon asked me to do something. Actually, if you start from the start, if you see this pit pattern is never malignant. It's type 4 or type 5 pit pattern. It's mostly it's an adenoma, and actually a histopathological analysis after removal, and you see the lifting signs is crucial. I remove it after a complete lifting of the lesion. I remove it for sure by a piecemeal technique. After removal, I applied argon plasma coagulation. It was so that decreased the recurrence rate, but actually in the recent guideline from European Society of Gastrointestinal Endoscopy, it had no effect on the recurrence rate, only it decreased what's called late bleeding. And this is the final appearance. You see before, during. If we want to take home message from this presentation, endoscopic therapy is the first line technique for resection of non-invasive gastrointestinal tumor. Surface and vascular pattern analysis is a very important to delineation of the lesion. Advanced histopathological analysis to follow up the lesion must be available. Lifting sign actually is crucial for EMR. Endoscopic therapy, combination of resection and ablation is preferred to surgery for sure for high-grade dysplasia and mucosal cancer. EMR is a standard of care for differentiated small carcinoma less than 2 centimeters of diameter. But actually the challenge is in the training for identifications and treatment. Thank you very much.